Welcome to Vatech monthly webinar series. I am Jim Mayer, Education Team Manager for Vatech. It is October 7th. This is our monthly webinar series. I'm Education Team Director. I have the pleasure of working with Paul Satone. Welcome, Paul.
Hey, Jim. How are you? Great to be back with you for our monthly webinar here this fine Wednesday.
Yes. This is the almost 15th in our series. We've been presenting since April 1st.
Yeah, absolutely.
And we've had the pleasure of having some great key opinion leaders in the industry join us for our session. No different today. We've got Dr. Ataii and Sal Rodas coming on. Paul, we've had the pleasure of working with them over the last 2 months for this sleep-based webinar series.
Right, absolutely. So today, October 7th, we had, like Jim had mentioned, we have Dr. Ataii and Sal Rodas back with us for kind of our third part in our series here on clinical applications and sleep disorders today. So, kind of starting from the first session we had with Sal a few months ago, we talked about the first session, we talked about the need for awareness in sleep disorders with Sal. And then last month, Sal led our session on the business of sleep dentistry. He discussed it from a financial sense for your practice, which was great. And all those sessions are on our website, vatechamerica.com. But last month, we also brought in Dr. Ataii as a guest to talk about his practice and his experiences, kind of leading us to this kind of recap for our session today.
For sure, yeah, we're going to get into a short recap of what we've progressed to, and then have Dr. Ataii come on and look at more clinical applications, looking at actually at some of the cases in his office that he is working with now and how it's affected his practice and overall his patients' overall dental health. Paul, we're going to bring them on here pretty soon. We do have our Fast Track Friday series.
Yep. Yep. So our Fast Track Friday series is going to continue.
So let's go ahead and talk a little bit about that.
Sorry, Jim. I think there's a slight delay.
It is. Go ahead and go ahead and present. Go ahead and talk about the Fast Track Friday series, and
okay,
we'll get that going with my slide deck.
Yeah, no worries. Technical difficulties. But yeah, our Fast Track Friday series will continue. Next month will be the 16th. So it's always going to be the third Friday. So we'll continue that on the 16th of next month. So we're going to have, previously we had 3 sessions set up. And what we're doing this time is we're going to have one large session, basically one session with 2 parts. There's going to be one login, so you don't have to log in and out. You can basically kind of hop in the session and hop out as needed. And that's going to be the 16th at 8 Pacific, 11 Eastern. And then kind of the second half is going to be 9:45 Pacific and 12:45 Eastern. So part 1 will be all about patient positioning and patient workflow and imaging workflow in the software. And then part 2 is going to be an easy 3DI clinical software review, and after that, clinical case planning. So lots packed into that, these 2 sessions we got coming up.
For sure. Paul, do you want to talk about a little bit of how to get a hold of us here at Vatech? And we do apologize for the screen share issues there.
Yes. So ways to communicate here. Jim, do you want me to go ahead and share my screen?
Yes, why don't you go ahead and do that?
Let's try. Give me a second here. Okay. Great. So if everybody can see my screen here, just some ways to communicate with us. We have our email address for the sales for any feedback on this and any future webinars at sales@Vatech America. We have the education team address email, so that email goes to our whole education team. So please feel free to reach out with any software-related questions whatsoever. And cs@Vatech America is our customer support email. If you don't have time to call support, it's a great way to contact support, and they'll get back to you as soon as they can. And also our website, vatechamerica.com, and of course, Facebook, Instagram, and LinkedIn at the hashtag @VatechAmerica. So
For sure,
here,
Paul. Thank you.
so Jim, if you can see my screen, I can do the PowerPoint if you like.
Perfect. Thank you. Go ahead, Paul.
Okay, so here on the screen, if everybody that's logged in should see the screen, we should see myself and Jim on top, along with the shared screen in there. If you have any questions, please feel free to use the Q&A section in the side panel on the right. Should be a floating side panel, the QA, and also there's a chat option if anybody wants to just type in the chat as well. If you have any audio issues, please click on the help icon up top. You'll see an option for sound check, and you'll be able to diagnose some audio issues that way. You should be able to log in with the computer audio or phone call, or the phone if you're having issues with the computer audio. So immediately after the session here, we're going to have a Q&A session immediately after the presentation as well. And from here, I'd like to welcome our guests here, Dr. Ataii and Sal Rodas.
Welcome, Dr. Ataii.
And
hello, everybody. Thanks for having me.
Yes.
Request.
And there is Sal. Welcome, Sal. Thank you for joining us today. There you are.
There we
Sal,
go.
your audio should be good.
There we go,
Perfect.
Sal. We can hear you now.
Yeah, glad to be here.
And Sal, we're going to go ahead and make you the presenter, and we can go ahead and get into your presentation.
Okay, great.
There we go. Great.
Yeah, so Jim and Paul, once again, thank you for having us here for our third and final session on the subject of identifying, treating, and managing patients that suffer from sleep disorders, and in particular, how we integrate the use of cone beam technology to achieve our goal. Without having to repeat a lot of what we've already discussed, what I will do is give a quick overview of the topics that we have covered, what we aimed to achieve by giving you that background information. And today we're going to close our session with Dr. Ataii presenting on real cases where he has actually delivered the therapy and how he utilized the cone beam technology to provide them with the clinical data necessary to make the decisions he made to be able to treat these patients. So by that, for those of you that may not know me, I am the product officer for Sleep Architects, but I'm also the executive director of a nonprofit organization called the Foundation for Airway Health. I'm also one of 13 task force members that are responsible for establishing the screening protocols for pediatric population that was appointed by the American Dental Association recently. So I do have several years of experience when it comes to the topic of airway management. And as I have in the past, I'm going to encourage any new viewer to visit the Foundation for Airway Health website located at airwayhealth.org so that you can list yourself for free as a resource, because we have a lot of patients that come to our website and they're looking for providers that could help them find answers to their questions. And as you will note, if you haven't been involved in sleep, you will quickly realize that we have a tremendous problem, but we do not have enough professionals to tackle that problem. So I encourage everyone, if you haven't done it already, to add yourself. There's no payment necessary for you to list your practice as a resource to patients. I also want to give you a quick summary of a recent event that we held. In fact, it was this past Friday, October 2nd. We celebrated Global Airway Health Day. This is an event that the Foundation for Airway Health put together in 2019. And it was an effort that we put together so that we could raise awareness in the general population about this problem. We reached some milestones. Number one is that we reached over 1 million people on the subject of airway health. So I also encourage you to visit the website globalo2day.org, O2 for oxygen. And you can read and see some of the videos. You could also access the 12-hour webathon that we produced for that day's event. So massive undertaking, and we hope to see you participate here on 2021, where we plan to do an even bigger awareness campaign. So those were my public service announcements, and let's get started. So as a quick overview, for some of you that haven't been doing sleep, you're probably interested in doing it because you're hearing from your colleagues or just from general correspondence out in the industry about the benefits of getting involved in treating patients with sleep disorders. So yes, indeed, the opportunity is big. We have an estimated nearly 1 billion people around the world that suffer from sleep disorders, and specifically in this case, sleep apnea. So when you think of the pandemic that we're dealing with today with the coronavirus, where we have an estimated 35 million people that are impacted around the globe, and then you overlay that with sleep apnea, you could understand that we're dealing with a bigger problem when it comes to the subject of airway deficiencies. But the problem is that most of us don't know what it feels like to breathe properly and not have sleep apnea. So for the majority of us, we walk around with a lot of these ailments without knowing that our lives could be better, or without knowing why, for example, we suffer from other medical comorbidities like hypertension, cardiovascular disease, so on and so forth. So just the subject of sleep apnea alone is already a tremendous problem. And once again, why I'm letting you know that we do not have enough of you out there actively looking for this problem and actually doing something about it. And when it comes to here in the US, at the very minimum, 20% of the adult population suffers from some sort of a sleep disturbance. So think about that. In your own dental office, at least 20% of the adults in your practice need your immediate attention. And if you're not actively looking for these patients, you're not going to be able to help them out. And by the way, just I want to say that there's someone with an open mic in the background, FYI, or at least I could hear him. The other things you should be aware of is that there's market changes, right? The general population is becoming more and more aware of their sleeping habits. Not only are they reading the news articles, but this is becoming a hot topic. You know, we have books that have been become bestsellers on the subject of sleep disorders. Arianna Huffington, for example, published a best-selling book on the subject, and most recently, James Nestor published a book called Breath, in the last month that has also become a bestseller because we're interested in knowing what happens to us when we don't breathe right, we don't sleep right. And right now, with the hyper focus of the pandemic, of the coronavirus pandemic, more and more the general population is becoming aware of the concept of the airway, the upper respiratory system. But we also have the American Dental Association's backing. In 2017, the ADA published an 11-point position statement encouraging all dental offices to actively screen and treat patients with sleep disorders when indicated. So, so much so that in Friday's event, the Global Airway Health Day that I mentioned earlier, the current president of the ADA, was showcased with his message in trying to get the American dental professional to be more actively involved in the subject matter. Again, we're dealing with a pandemic. We need everyone's hands and feet actively involved if we want to make a dent. And we also have new practice parameters that have been issued by the American Academy of Dental Sleep Medicine, encouraging practitioners to not just deliver widgets, but instead to actively be involved in a patient's long-term care management. So there's also a shift for those that have been doing dental sleep medicine to realize that the new practice parameters want you to look at this patient from a long-term perspective. Because as you may know, if the patient is diagnosed with sleep apnea, for example, and they have to wear a CPAP, which is the gold star treatment today, that CPAP device will need to be worn by the patient for the rest of their lives. And the same is true for the use of oral devices. Patients with sleep apnea that are being treated with an oral appliance will need to wear these devices the rest of their lives. So your treatment protocols for patients with sleep disorders should include a long-term management protocol to monitor the patient's condition for the rest of their lives. And that gets you to shift your mentality away from the widget model where you just deliver the appliance to this holistic model of looking at a patient and treating that patient and collaborating with other physicians. So again, I want to remind you that I actually dived into this topic in more detail in our previous sessions. So go to the Vatech America's video library so that you could see these webinars. But the realities that most practices are facing, number one is that if you're not doing sleep today, you want to get started right away. So you could get started by actively screening. That is the first action that you could take to begin to make a difference in your community. We talked about the subject of medical fraud and how some practices only like to get reimbursement fees from the medical insurance company and not charge patients out of pocket. And we talked about balance billing. So these are some of the things that we talked about in our previous sessions. The bottom line is that there is no such thing as medical insurance fraud unless you actually commit fraud. And the concept of only collecting the patient's out of pocket is also, only collecting the patient's medical reimbursement is also an incorrect way of engaging with your patients, right? You should consider both because you need to collect for your fees. Otherwise, you won't be doing this for a long time. And we talked about the insurance game and how you have to be persistent in making sure that insurances are reimbursing you for treatments and services that you're rendering when they are medically justified. Because you should know that treating patients with sleep disorders using oral devices is covered by all commercial insurance payers. There's no reason why patients with benefits should not be getting the coverage needed and for you to get the reimbursements when indicated. So we talked about that previously, and we talked about the billing realities, how it's easy to submit insurance claims, how it's very time consuming to do your verification of benefits, the AR follow-up, and most importantly, the denial management, right? These are all of the billing challenges that your team may face when you begin to bill medically. And then we also talked about patient responsibility. How much will the patient have to pay out of pocket given different scenarios, right? Because every situation is unique to the individual plan that the patient has. So you cannot assume that because one patient's case reimbursed you, let's say 80% of what you billed, that the same is going to be true for another patient with the same insurance plan. You have to take on other variables. For example, what is the patient's deductible and what is the patient's coinsurance? And when you combine these numbers, you will then have a better understanding of the type of reimbursement you may get from the insurance company and how much to charge the patient out of pocket for their responsibility associated with their care. Again, we talked about balance billing. When it's fraudulent, as opposed to when it's not fraudulent to do balance billing. And the summary of that discussion is that as long as you are not contracted with an insurance carrier, you run absolutely no risk of falling into this concept of balance billing being illegal in the US. And the other takeaway is that not all states have such mandates. In fact, there's very few states in the nation, about 13, that it is illegal for contracted entities to balance bill. And largely, this impacts more hospitals than it would even an outpatient clinic. But again, you want to be informed and you want to know about that. But this is something that we covered previously. And the bottom line when it comes to medical insurance, because this is probably the single most important attractive factor for dental offices to get involved, is the possibility of getting reimbursements like the one you see in here. A check for $4,600, for example, a reimbursement for the cone beam scan and the consultation at $836, or $7,500 for the oral appliances, right? These are the possibilities, but you should know that you're not going to hit 100% home runs every time when it comes to the medical insurance game. So the bottom line is that back in 2016, this is 4 years ago, here in America, the total US spending on OSA treatment was $170 billion, right? This is the combination of CPAP therapy, surgical interventions, and the use of oral appliances. So from a business perspective, and this is why dental sleep medicine is the fastest growing modality in dentistry today, there's plenty to get to generate revenue with. The challenge is that when you have your dental hat on, at first, it's difficult to transition and also now add your medical hat, because to provide this type of therapy, there are a few medical steps that you have to add into your office to properly bill, get reimbursed, and or to treat the patients when it comes to this subject, because dental sleep medicine means that you're rendering a medical treatment for a medical condition, right? And that's why I always talk about the fact that as dentists, you are physicians. And I don't just like to, stroke your ego, but this is the reality, right? The American Dental Association describes a dental, a DDS or a DMD as a physician. And when you think about it, it makes sense, because you are the only physician in the group of healthcare providers that has the expertise on how to manage not just the oral cavity, but also the adjacent and associated structures and how those impact the rest of the body. So that is the importance in understanding that you're a physician, and not only for you to understand what your scope of practice is when it comes to the subject of sleep medicine, but also for you to understand that this is why it is permitted for you to bill for medical services when they are justified, right? And this is why we highly encourage the integration of cone beam technology to manage patients with airway deficiencies, because in our opinion, this is the only way that you could successfully identify the clinical markers that will help you develop the best treatment plan for the patient, and most importantly, also help you educate the patient so that they could own up to their disease. Because as I mentioned already, most of us are not aware as to how bad our breathing is impacting our lives until we start looking under the hood. And again, this is why the use of cone beam technology to us is imperative to be able to accomplish not only that education for the patient, but also for us to develop a proper treatment plan. And when it comes to cone beam technology, the beauty is that most of the technology today will allow you to do fast scans, and depending on the type of cone beam device that you are interested in or that you engage with, if you're referring patients to an imaging center, the field of view is an important factor in determining what is the ideal cone beam image to use. So we talked about that field of view, and in short, you want it to be at the very minimum 15 centimeters in diameter and 13 centimeters in height, because that will give you enough clinical data to determine how to treat these patients. But it also helps you from a medical reimbursement perspective, because if you're not capturing the right anatomy, you do not have the medical justification to perform that scan and get reimbursed for it. So it's a multi-pronged approach. And then from a clinical data perspective, having the ability for you to perform a comprehensive airway analysis and provide the patient with a comprehensive treatment plan, because patients with airway deficiencies also need their restorative to be looked at. For example, they may need orthodontic intervention. So being able to look at that cone beam data set will give you sufficient data to be able to provide that type of a comprehensive care management for your patients. And lastly, one of the topics that I discuss is the practice workflow. How do you develop a medically justified airway management protocol so that you could get reimbursed for your services? And in summary, we discussed in detail how you initially get the patient through a screening process. If you have a cone beam machine, at that point, you do a baseline cone beam scan of the patient. We went over the details of getting the patient tested with an overnight sleep study, whether it be an at-home or through an in-lab. Those are the options available to patients. And then the most important part is the collection of all this clinical data and being able to present it to the patient in a way that the patient could own up to their disease, right? Because if the patient does not accept treatment, you won't be able to make an impact in that patient's life. So to us, the case presentation is the most important piece out of this entire equation. Then comes the comprehensive examination of the patient so that you could identify any potential contraindications, for example, joint dysfunction or not enough retention because the patient may have missing or mobile teeth. And then once you've done your clinical examination, taking the impressions, the bite registration, and then getting the appliance fabricated so that you could deliver the appliance. And once you deliver that appliance, we recommend another cone beam scan that will allow you to document what the appliance is doing to the anatomy, and also help you educate the patient again on the intended outcome of this device in the patient's mouth. And lastly is the billing and reimbursement, right? Being able to bill for every consult that you take the patient through this process from, consult one all the way to the long-term management to support the patient, to bill for your cone beam scans, and to bill for your appliance therapy as indicated for that individual patient. So again, we went through this in detail in our last discussions. But the bottom line of that workflow, again, is to develop what we call a comprehensive treatment regimen that creates that medical justification, taking the patient from medical diagnostic evaluation, the collaboration with other physicians, because when it comes to sleep, you have to get the patient diagnosed by a sleep specialist, for example, performing that comprehensive examination, developing the ideal treatment plan for the patient, delivering the appliance, and then having the patient recalled in the proper sequence so that you could follow this patient through that long-term management, right? Minimally, 2-year airway management regimen is what you want to implement for your patient if you want to follow the current practice parameters as issued by the American Academy of Dental Sleep Medicine. And if you do nothing, we talked about that oftentimes this is what happens to patients. They end up with heart attacks. And if money is a concern, look at what the amount of money it typically costs to handle patients that suffer from a heart attack. So there's plenty of motivation to actively screen, treat, and manage these type of patients. And the hope for us is that you develop an objective in your office, and that is to identify your patients, treat them, and manage them. Because as dentists, this is what your role is. Again, if you want to be in compliance with the position statement from the American Dental Association, right? Oh, sorry. So with that, I want to bring James or Paul on the line, because I want to once again share with our audience the benefits that we see in incorporating cone beam and why the technology is so important to us, why we even agree to have these discussions and partner up with companies like Vatech. It's because we want to encourage all of you, if you haven't already made the investment, to consider making an investment in cone beam technology so that you could get better results with your patients and so that you can really tackle this problem. So Jim, if you don't mind sharing your screen, I would like to kind of just walk through some of those benefits with the audience here. And right now I could see my
Sure,
screen,
Sal.
but I can't see yours. Yeah.
We've got Paul's 3DI shared. So Paul's going to go ahead and run through some of the software while you're going through your introductions there.
Okay. So, oh yeah, there it is. Sorry, I was looking at my screen there. Yeah. So, here Paul has an example of a patient that has a highly impacted airway. And again, most patients are going to walk into your office. They may not walk in saying, "Hey doc, can you help me? I can't breathe in the middle of the night." Maybe the spouse is saying that the patient snores, but the patient might be ignoring it. And unless you're asking or your team members are asking the questions, you're not going to lead the patient through the process of helping them own up to their disease. So this technology, again, gives you not just the clinical data, but it gives you the presentation tools so that the patient could visualize what's happening to their airway in the middle of the night. Even though you're performing a scan during daytime hours when the patient is awake and the patient is standing or sitting, depending on the type of cone beam image that you're taking, the results of that cone beam scan are still tremendously going to help you explain to the patient how much worse the airway becomes at night when the body is relaxed, when the body is at its most immobile state, and the soft tissues are collapsing, creating the snoring and apneic events. So what Paul is showing you here, for example, is the ability to measure the smallest aspect of the airway. In this case, I think it's the oropharyngeal space, near the soft tissue. And it's showing you also how you could travel through that entire pharyngeal space that starts at the tip of the nose all the way down to the back of the throat. And you could help explain to the patient what's going on. But beyond the patient, other consumers of this image include other physicians that you will collaborate with. For example, sharing this image with an ENT would be a powerful way to co-manage the patient's condition, because oftentimes patients with airway deficiencies are mouth breathers where the nasal cavity is impacted, and the intervention of a properly trained ENT is invaluable. So being able to share this type of data with other clinicians will also probably create a better collaboration so that those doctors could refer patients to you, right? Because the majority of physicians are razor focused on treating patients with cone beam, oftentimes not realizing that oral appliances are a great alternative for patients with these conditions. So with that, what I want to do now is I want to introduce you to Dr. Payam Ataii, who's going to be walking us through some real cases. Dr. Ataii, I'm sure many of you know, but if you don't, Dr. Ataii is an accomplished lecturer. He's a KOL for many companies, and his expertise, in my opinion, is the ability to really break down these what could be sometimes overwhelming subjects into sound bites that are accessible for you, the clinician. So, Doc, I could spend probably about 30 minutes really introducing you because you have so many accomplishments. But why don't you walk us through your segment? And I appreciate your time here today.
Sure, absolutely. And thank you
Thanks.
very much for that time. And I always, it's a pleasure talking to my peers and colleagues and team members about the benefits of what we do every day in dentistry. And that's really the key, right? So we see patients, and even given today's time and climate of having to deal with, as they call the pandemic, and dealing with the situation we're in, what we see every day as dental physicians, as Sal just talked about, and really as dental physicians, we see the oral cavity, as you mentioned, from the nasal cavity, oral cavity. The reality is the teeth, these teeth that are degrading. Why are we having teeth that are worn down? Why are we having teeth that they have abfractions? Is that because the patient's grinding at night? They're stressed out? Yeah, pandemic could be blamed for that. They could be stressed, true. But prior to this, did we see patients that had an oral cavity that I'm showing you on the screen with the worn down cusps? It looks like, divots in a grass on a golf field, those of you dentists who play golf, and the lower mandibular arch that you're looking at, the lower cutting, because we know that shift happens, right? So when we start to look at these types of patients, we have to take into consideration that it's not just the stress. It could be bruxism. It could be what now we are realizing in the world of sleep medicine, that these lower anterior teeth that are crowded, that are narrow arch, tori, worn down cusps, eventually these patients degrading their enamel structure, and we're breaking down their vertical. This is actually my uncle in Canada. My uncle passed away from sleep apnea. Now, granted, they at the time were wondering why he had such worn down teeth. This is a photo that I took on him about 6 years ago, prior to his passing, of my aunt telling me, why is he wearing down his teeth? I said, my gosh, is he wearing a CPAP? Is he wearing an oral appliance? What is he doing? They said, what's that? What's sleep apnea? So now we know that there is a protective mechanism called nocturnal bruxism, that patients who have sleep apnea, when they lean or lay flat on their back, as their mandible drops and they say, I just snore, my mouth is open. True, but what happens? Do you consistently slow? You don't consistently take in air. At one point, you have to exhale. That exhale, that problematic scenario where your mouth is open and you exhale out, that is enough to have forces that are not wanted, and you end up getting bruxism, clenching, grinding, and worn down teeth. Now, a lot of studies have been showing us this, but I actually was able to print this and talk about sleep treatments that are given to our patients from the dental practitioner. So let's talk about some facts. Well, first of all, humans are born with 300 bones, right? What does that have to do with anything, Dr. Ataii? Well, think about this. As adults, we only have 206. So we start talking about, are we losing bone? No. We're going to get to that. The fusion of the bone or the floating of the bone. Think about the maxillary upper palatal arch of that. Is that considered 2 or 1, right? The sutures. So we'll get to that. Let's talk about the brain. Only uses 2% of the person's body mass is what the brain is, but it uses 20% of the body mass as oxygen. Okay, when you start to look at these facts, and now the shocking fact of sleep apnea and the being in 20% plus of adult population, and these patients, some of them are presented with potentially mild to moderate. This was back in 2002. What are we at 2020, right? 100 million Americans snore. And yes, snoring is not necessarily sleep apnea, but as we know, we have got to understand that ends with potential apneic events. We've got to screen these patients, test these patients, and look for these people, because 65 million who have misaligned teeth have oral poor dental health. Okay, so let's talk about that. So why do we need to see? Well, Sal did a very good job in talking about what I remember in gross anatomy, this entire nose, mouth, anything above the neck, it is our department, dental physicians. So sleep disordered breathing is part of our regimen of screening, as so is oral cancer, periodontal health. So when you start to look as human beings, we're the ones who have complex speech. We can talk. We have a true oral pharynx. Therefore, that oral pharynx needs to be protected, needs to be patent, needs to be open. Now, I talk about this, and last time there was a question asked about, well, how do you screen patients? You just throw them in the CT machine and take a CAT scan on every patient? Yes, I actually do. Yes, I do. It's my screening tool. It's part of my tool of getting diagnostics, of checking the airway. So the question rises, am I getting radiated? My hygienist was completely opposed to getting patients taking a CT until I showed her what the true radiation dose is, because radiation doses are converted or are recognized in sieverts. So when you're actually taking microsieverts, which means that in basically, if you're sleeping next to another human being, you're getting radiated. How's that possible? Well, think about it. If you go on a plane and you go up in the air, there's radiation. If you are walking in a atmosphere, there's radiation. There's sunlight. There's always radiation. So this microsievert is radiating, and you yourself are emitting radiation. So one human next to another is actually getting radiated. So let's talk about this and putting in perspective. So 0.1 microsieverts is about eating a banana. One banana gives you radiation. How many bananas do we think I have to eat? Well, half a banana is sleeping next to someone for one night. So my wife and I have been married for 18 years. A lot of radiation there. Now the question becomes, how many microsieverts of radiation is given to a patient who's taking a CT scan? About 40. Now you can have short scans, which are less, or you can have a longer 13-second long scan. Well, just to do a quick perspective of putting it in order of a full mouth FMX, that's anywhere between 100 to 170 microsieverts. So full mouth X-ray gives you actually more radiation than a short scan of your CT. Now, do you see more or less? Well, let's think about this. A 15 by 15 shows me a lot more. Into proximal cavities, I may not be able to catch as well, but there's a trick for that too. However, if you're going through an orthodontic treatment, a workflow, you're taking an initial pano or a lateral ceph, posterior ceph progress, and then you look at another 24 months of potential exit. All of these equal a lot more scans and radiations than you just doing a workflow for a 3D sleep of my initial, progress, and final of these short scans, which gives me anywhere between 80 to 90 microsieverts. So when you start to put this in perspective of managing the patient, it's very common for patients to have the fear factor, given if your team or your staff members don't know the answers of radiation. Because the American Dental Association actually recommends that clinicians perform dental x-ray examinations, including dental CBC, when necessary for diagnosis or treatment of disease, as a clinical benefit of medically appropriate x-ray imaging exam outweigh the small radiation risk factor. So we have to talk about this. And I too have a little form that I mentioned last time that I give to my patients of whether or not you want to have this CT read by a radiologist. I can have a radiologist read it because my job is to look at the the oral cavity. But if there's something that we might miss, maybe you might have some sort of cancer or something that's in there, I don't want to be responsible for that. Why don't you sign here and we'll have a radiologist read it? Or the patient says, no, I don't care about having it read, no problem, because they don't want to incur the extra $150 extra fee or something like that, the cost is for me to have a radiologist read it. And again, Sleep Architects, I partner with them. They actually have a network of doctors that can read these for you. My point to you is that we cannot practice out of fear, right? We have to be able to practice as standard of care. So when Mary comes into my practice with a bridge on the anterior, missing teeth, and I'm trying to get the bridge out of the way because she's got decay, she's got all kinds of implants I need to place. The airway is important because that nocturnal bruxism, that grinding, if this patient has an airway that's constricted, guess what's going to happen to every restoration I give her? At what point do we decide, hey, I'm just going to do the implant, I'm going to do the bridge, have a nice day, or do we actually give the comprehensive care that the patient deserves? In now seeing, guess what? I even found a root canal that was failing that my x-ray didn't show under the bridge. So extractions, bone graft, implants, all of those things can follow, including sleep, in a typical dental office that has a tool like a CBCT next to them. Being able to utilize these technologies for patients' enhancement of their smile and their airway is key for me. Combining the clear aligner therapy, well, it's a slam dunk in my practice. I kind of use every asset, and I will go through this entire clinical process of putting patients of those narrow arches, expanding arches, putting patients in oral appliances while you're doing, even if you choose, full mouth reconstruction or just that single little filling or implant the patient wants to have done. So let's go a little deeper into that and talk a little bit about the clinical signs and symptoms of OSA. So at that point, we'll get into some cases, okay? Peter, right? Peter just standing still, that's him standing still. His neck, you see, looks like he's stretching a bit, right? And you look at this patient, and as we start to go in our 5th, 6th, 7th decade of life, you start to notice that, our neck kind of comes out a little bit forward. Why do you think that is in some of these patients? Well, it's not because they're standing like this. Could it be that they're getting better airway because the neck stretches out? The breathing gets better versus the neck going back, constricted airway. Think about your mandible. If you push your mandible back, what happens? You can't breathe. You can't talk well. You bring the mandible forward, my air gets better. Why does that happen as we start to age? Is it because our bone density is getting weaker and we're kind of cramping down? Well, yes, that's part of it. And we start to neck forward getting air. So if you start to look at the position of the mandible, of where it likes to be as we start to progress in our age, the mandible likes to be where? A little bit more advanced to get more air. Now, does that help the joint? Does that help the jaw? That's what my scan is for. That's what I use the CT for, because as you can see, just putting him in an edge-to-edge bite, I did not advance. It looks like the mandible is advanced, but I only advanced it to his anterior bite, where he's just about 3 millimeters. That small 2 or 3 millimeter advancement of the mandible, where he's now edge-to-edge, rather than all the way forward, where the mandible goes to Timbuktu. I don't know where to put it, but the patient said, I can breathe better. Well, how are you going to sleep at night like this? But I can breathe better. You're going to have TMD issues. Well, I can use my scan to kind of see and help the patient understand this is what we're aiming for. Look at the airway on this patient without the appliance and with the appliance. So this is the key factor in understanding why we do what we do. So let's talk a little bit about these patients a little deeper and going and looking at malocclusions. Do malocclusions equal sleep disorders? So if your patients have crooked teeth, narrow arch, could they have a sleep disorder? Well, let me put it to you this way. Have you seen patients who've got worn down teeth with tori? Have you seen patients who've got completely crowded teeth, and they may have a tongue that's just protruding out. So look at this patient's tongue position before any kind of therapy with, in this case, let me go back to the slide, I apologize. We look at the patient's case on the lower arch, lower crowding, cuspid rotated out to the lower lip, tongue is just kind of constricted and being pushed back, versus we expanded the arch, we proclined the teeth forward, and look at the tongue. Just that few millimeters of making room for the tongue and that few millimeters of just uprighting teeth. Do I have to advance the mandible forward? No, because just by simply uprighting the teeth, I created room for the tongue to rest at the floor of the mouth rather than in the back of the throat. So when you start to look at these patients, it's not about just throwing a night guard over them, and because they have worn down teeth, here's a night guard. No, actually 4 out of 10 patients get worse. They go from a mild sleep apnea to severe, and their AHI index actually increases. In Gagan, in our Prosto book that I remember back in the day, I graduated in the late 90s, and they never talked to us about sleep apnea. They never talked to us about tori, that it could be potentially from nocturnal bruxism. What is that? It was all about night guards, CR splints, how to make a proper guard for the patient. What are you guarding? You're actually making the patient open, and the patient takes the guard out and says, I actually sleep better without this thing, right? So we have to create and understand airway. And it's not just for the fat men. It's not the Homer Simpsons in the world. It's for everyone. Everyone has sleep-related disordered breathing if they are either snoring or they're having apneic events, or potentially, like I mentioned, worn down teeth, abfractions, and crowded teeth, and the malocclusions that come with sleep breathing disorders, and women as well. As a matter of fact, some of these women who are actually skinny and thin women have significant obstructive sleep apnea. And let me show you my own assistant, Nadia, back in 2014, when I was kind of dabbling and getting these cases done. She said, hey, Doc, I'm always tired. And I looked at her, I said, gosh, I thought you were just partying. She goes, no, I actually go to bed 9 o'clock at night. I wake up and I'm exhausted. How's that possible? Look at under her eyes and look at her demeanor and her neck structure. I want you to just look at her neck. That's her standing. That is her with the lower mid-maxillary that seems to be protruded, just like you can see. She's got like a class 2 anterior. She's got some crowded, rotated teeth. She's got the tongue that's attached to the floor of the mouth. And then you've got yourself her airway. Well, let's take a look and just kind of what we just experienced earlier, looking at her airway and kind of seeing this patient from a screening perspective of how narrow that airway space is. And if you start to look at this patient and you start to go through, you start to see that when they lean and sleep flat on their back, what happens to that tongue? What happens to that airway? It's going to get constricted. That is going to get actually more constricted. So in Nadia's case, simply uprighting the teeth, proclining the lower mandibular forward, kind of reclining the upper arch back, correcting the maloccluded area. And remember, I still haven't released the tongue. I haven't, there's a frenum still that she's got a little ankylosing going on. I still haven't done that yet. She feels a little better. I want you to look at her neck and look at how she's standing now. And sure enough, I combo therapied her with clear aligners, and I used the aligner sleep appliance. So at night when she's sleeping, the mandible doesn't drop back and block her airway. So the ASA, the aligner sleep appliance, was able to help her not drop the mandible back and block her airway. And this is the key for these patients. And at night when she's sleeping, she's got somewhat of an edge-to-edge anterior, a little bit advanced on the mandibular, but now we're correcting the malocclusion, and we start to bring the lower back. We don't have to have it so far forward, and now we can have it meet the upper arch and potentially sleep as she would normally in having that malocclusion, narrow arch, deep anterior by corrected. This is what the difference of these patients and the difference that you can make by just simply screening. Now, when you look at these patients, and by the way, those doctors that are really want to dig deep, there's a lot of publications I've done multiple cases, and you can reach out to either Sal or your Vatech library that can give you some of these different articles that I've put together in talking about these different cases of combo therapy versus monotherapy, of doing sleep appliances only, or actually, as Sal said earlier, treating these patients, not just bandaging them with some sort of an oral appliance, but actually treating them. So let's talk about Susan's case. Susan's case has always been enjoyable for me because she's always been a fun gal. She had TMD. Her teeth, a little bit on one side, had a little bit of edge-to-edge bite, kind of a deep bite going on. It went to multiple doctors, and her joint hurt. She always had issues when she opened and yawned, popping. And look at the tori on the floor of her mouth, right? Not as much worn down teeth, but they look a little flat. And I told her, I said, I think that ideally we need to kind of put your teeth in better bite, put her in a little better occlusion. At the same time, when you look at her airway without any protrusion of the mandibular versus just getting her edge to edge, I don't want to go overextend the mandible. I don't want to give more TMD issues. She says, Dr. Ataii, I don't know what happened, but my pain is gone. And my husband says I don't snore anymore, but I feel better. So all we simply did was upright them, upper and lower arch, put the teeth back where they belonged, and give her an appliance that at night stops her or blocking her airway and her having that nocturnal bruxism because she's trying to get air at night. Her body's trying to wake her up. Breathe, breathe, breathe. Right? So what happens when you start? Then you pause. There's the apneic event. No air is going in. And then you blow out. That process for her was stopped. So again, another case that was a peer-reviewed article. The patient was excited about having these treatments done. So there's a lot of need in seeing the CBCT, educating the patients, and again, you're going to see patients in your practice, and we'll just go through the workflow that the field of view is important. Getting a CT for me just to see for implants is not enough. I need to be able to see these patients' entire upper airway. And for me, it's key because these patients exist. They come into practice. He was so excited. He gave us a testimonial and kind of just going through and showing him what his nasal, oral, and why we need that air at night while we sleep. The treatment is very easy for me. It's very easy for me to have the conversation. It's very easy for me to start the treatment. So I'm hoping that this kind of gives you an idea, but let's look at Kevin's case a little closer, because in his particular case, he had about 8 events every hour, meaning 8 events that he didn't get air for 10 seconds or more in his lungs. So let's just count to 10. 1, 2, 3, go up to 10. Well, hold your breath in that 10 seconds. Let's do this. This is just be fun. It's just 10 seconds of a webinar. So everybody take a deep breath and hold your breath. 1, 2, 3, 4, 5, 6, 7. Don't breathe. 8, 9, 10. Now breathe. That's 10 seconds repeats itself 8 times in an hour that patient, that the body, to 20% oxygen that's needed, is not getting to the patient's lung, limbs, brain, toes, and that patient is going to be exhausted. Now, by doing the therapy, by simply having the scan, putting the patient through the processes of getting the treatment done and an oral appliance, you can see here that his events went from mild, which was 8 events per hour, down to almost nothing, which he ended up at 2 events per hour. Now, we have to calibrate and advance the mandible. We have to do some adjustments, but this helps the patient. And I did not have to bring the mandible too far forward, only 2 millimeters. I wanted to show this, that we don't have to advance the mandible forward all the time. Sometimes it's the vertical, sometimes it's a type of appliance, sometimes a type of treatment. So our patients can benefit from our knowledge, our technology, and most importantly, getting better oral health. So it's always the idea of that it's too expensive. No. Dentistry is not expensive. It's the problem that the patients don't trust us. 59% of the patients, when the poll was taken out of 25,000 patients, as to why did you not accept the treatment that this office had to offer, 59% said we didn't trust the office. 23% were afraid. 10% were confused with the treatment plan. They don't even know what they're doing next. Only 9% said it was because of cost. I've shown the slide since 2010. And I tell you, it's an eye-opener, because trust. And that's what I need to bring for my patients. And that's the reason why I invest in technology. So I hope that gives you a quick little glimpse of how I do it in my practice, and the key questions that I ask before I get into treatment any of my patients, in taking the medical history of, do you have headaches? Do you have facial pain? Do you brush or grind your teeth? And do you snore? That is my lead in to have the conversation about nocturnal bruxism, of grinding, and the idea of night guards. Now I start to educate the patients when they see their airway. I hope that gives you a quick glimpse. And if you have any questions, I'll be more than happy to answer it. And I know that my time is up, and we'll go into the Q&A.
Thank you, Dr. Ataii, for your presentation.
Welcome.
We do have a few questions, and I think Paul's going to come back online here. We do have a few questions that came in. In your experience, will the insurance pay for a follow-up CBCT after appliance delivery? Or
Yeah,
maybe that's
so
what are you finding?
I'll take that one first, and I'll have Sal. So look, for me, I have a whole bunch of insurance checks that I can put up, and the answer is, yeah, I mean, if the patient has coverage, and we've already talked, like Kevin's case, I've gotten multiple checks in Kevin's case because you're consistently following up with that patient, right? So 24 months is what we've been told that standard of care is to follow this patient through. So I'm going to need 1 or 2 or 3 CBCTs during that timeline. The question now becomes the deductible, how much should they pay? So I've gotten checks of $1,200, and I've gotten checks of $200. On average, I'm about $500 or $600 when they have an insurance PPO that has the coverage, but it's not all patients. Not all patients some have Kaiser, some have HMO. So I kind of combine in my treatment, if it's a $5,000 or $6,000 treatment, and that's the way I treat my sleep patients, just like my clear aligner patients. $5,000 or $6,000 for clear aligners, $5,000 or $6,000 for sleep treatment, and that will include the CBCT, 3 to 4 of them during that timeline.
Right. Perfect. Thank you. Did have another question. You were talking about, building trust with your patients. At what point, you scan the patient? When are you showing them their airway scan? Do you have a formula that you kind of go through when you bring them in? I guess your staff does a Q&A. We identify these, and now let's show you the real, hey, this is you. Yeah.
So I've been blessed to partner with sleep architects, and they have a whole, I call it a 12-step program, right? They have a whole process of what to do at what point. But in simple terms, yeah, the patient comes in, that's our intake, right? We do the perio charting, do the oral cancer screening, do the bite wings or FMX should we need it, and the scan. At that point, if we are the CBCT is being taken, I don't go read it right away for the patient. We talk about the radiology of it. If they want to have it, a radiologist look at, or we can just kind of go through and do a quick airway interpretation. And then we look at any areas of failing restorations, potentially at the roots, like root canals, any retreatments, or any history of issues in periodontal if we can see on the CBCT, which 99% we can. So that conversation usually happens on the second visit. I bring them back in, and we kind of review that as sit down. The initial visit, it's the wow factor. They see their head. We can move the cranium around. We kind of show them the airway, and we tell them this is why we took this image, and we'll bring them back to actually do a full diagnostic workup. I don't like in the first visit giving patient all this information. It's too much data because they want to know about their filling. Is the white covered? Is the crown covered? That's what they kind of want to know.
Right. Thank you. Dr. Ataii, you kind of alluded to Sal's, 12-step program or leading, here's the process that you do that. Sal, can you talk a little bit about sleep architects and what that process involves when dentists team up with you?
Yeah, I would say similar to the the AA program. The first thing we do is we ensure that clinicians admit to themselves that they're physicians, right? That kind of kicks off the whole thing, and then. But our program, really, in summary, is a comprehensive solution, especially for practices that are looking to get started and have not begun to do sleep or have tried to do it but found it difficult. Our program trains the entire team, both clinicians and staff members, on how to identify and how to manage these patients from a long-term perspective. We also facilitate the dispensement of home sleep testing devices. Our physicians will then interpret and diagnose the patients. So there's no need for the practice to have to buy equipment. We actually fulfill that on behalf of the practice. And then I would say our real muscle is that we collaborate with the clinician to develop the ideal treatment plan. So depending on how much technology the practice has, we support them. So if the practice has a cone beam, for instance, we have them share the DICOM image set, and then we'll have our clinicians develop with that doctor the most ideal treatment plan. And then we follow the patient's treatment and management throughout the entire long-term care management. And from a medical billing perspective, we do the verification of benefits from the very beginning. We submit the claims on behalf of the practice. And then our real muscle there is that we do the ongoing follow-up management, and we appeal any denials in an effort to try to overturn the denial and get the patient the practice reimbursed for the medical treatment if the case is justified. And the way that we outline our quote-unquote 12-step program is in a way that every step is medically justified so that you can bill for that consultation and get reimbursed. So that's what our program is all about.
Perfect. Thank you. We do have another question coming in. Specifically, will implants support an appliance, whether partial arch, mini implants, or full arch implants?
So let me help with that. It's not necessarily the question is, can an implant support an appliance? And the answer is sure. It can support a denture, it can support a crown, it can support a sleep appliance. The question is the appliance that's being fabricated where the mandible is advanced to a point where that bruxism is going to put unwanted stress on the implant? And that's where, again, the technical side, you need to partner with, again, I partner with sleep architects, but with technicians and clinicians that are aware of stress factors of whichever implant you choose to use, whether, whatever name brand. And in my world, I have done mini implants that have supported oral sleep appliances, and I've also done where the actual implants are over dentures. But overall, for a single unit implant, if it's in the patient's mouth, like you saw in the prior case I just showed, yeah, I mean, I put sleep appliances over implants all day long. It all depends on where the patient's airway is most patent, right? Where are you bringing the jaw here when the patient sleeps at night? Could potentially put a lateral force on the implant and degrade the bone, and you lose the implant.
Right. Another question: are you scanning the patient with the appliance to evaluate the joint?
So yeah, so if you saw earlier in the slides, I always do an intake, which is our initial scan. And then when we deliver the appliance, we have the scan of the appliance to check the joints, to see also the airway. The patient kind of sees it. But I do a follow-up sleep study with the patient's appliance and without, again, and there's multiple devices now that patients get. And again, I go through sleep architects. That's part of their workflow where they send the patient the testing unit, and at that point, the patients were actually seeing the AHI, whether or not it was effective in that position that I kind of calibrated. And that's usually a standard with me. Yeah, with appliance, without appliance is important for me.
Gotcha. I do, excuse me, Sal, I do have a question for you on your, I guess, training protocol for offices that work with sleep architects. What has your experience been with, getting, I guess, acceptance from the staff members on asking questions, recognizing those patients? What is the kind of the protocol that you take the staff members through, saying, here's how we're going to do this, the education you provide them on recognizing patients?
Yeah, it's a good question because, it really starts with the practice as a whole embracing this concept, right? It could be overwhelming and challenging at first because we're talking about a new language. So the way that we tackle that is that we have a progressive learning experience for our practices. We do not try to get the practices to swallow the entire curriculum in a short amount of time. In fact, our program begins with a foundational 6 to 8 week program. And I say 6 to 8 because it depends on the scheduling of the practice, where we're giving the practice as a whole, again, sound bites on how to learn these concepts, right? We go over not just the screening protocols, but we also go over the subject of medical insurance, because oftentimes the patients are going to ask questions, and empowering the team as a whole to embrace, number one, the prevalence of the condition, how many people suffer from the problem, and how easily they could ignore the subset of the population if they're not really looking, right? If you are biased and you say, oh, that person has a sleep problem, but that one doesn't appear to have one, we have failed at training that practice. So one of our number one priorities is to transfer that knowledge so that the team understands that it doesn't matter how old you are, it doesn't matter what gender, it doesn't matter what size you are. This disease can impact anyone. And how do you identify the patients? Then we walk them through the administrative process of documenting the cases in a way that they could be medically justified for medical billing purposes. And our training also includes setting the fees properly according to where the practice is located, because that is a big component of being properly medically reimbursed. And part of our training is also developing a suite of marketing tools that the practice will utilize to educate their patients and or local community on this subject. So we have had a range of success from practices, some that are able to actually follow the tempo that we provide them with. And we have had a set of practices that are not as successful because of changes in staff members at the office, or maybe the perception that the team is too overwhelmed as it is already with their existing assignments. So it is a priority for us to win the hearts and minds of the team members, because at the end of the day, the majority of this work is actually being delivered by a team and not so much by the clinician. The clinician is just involved in the clinical exam, educating the patient and monitoring the patient's progress after delivering the appliance. But the other work really is on the shoulders of the team members. So we do put a lot of emphasis on that. And as I said at the very beginning, most importantly, case presentation. How do you get the patient to accept treatment when maybe they came in for a tooth cleaning and now they're walking out with, that they're a walking time bomb because they have an untreated condition, right? So we do spend a lot of time educating the team, including the clinicians, on how to properly present this serious situation with their patients.
Perfect. Thank you.
Mm-hmm.
Let me see if we have any other questions on the board. Paul, do we have any other questions coming in? I'm going to check my notes here too.
Somebody's asked, there's a couple questions in the chat. One is regarding the scan size. Could somebody just talk about what the optimal scan size? I think this doctor that is asking the question, has a 10x8 scan size, and is there any options if they have a smaller size?
Sure. Doc, if you don't mind, I'll address this only because this is an area that I've spent a lot of time. In fact, I published a white paper specific on field of view. For those of you interested on the white paper, when you request your CE, just put on the notes to have you us send that white paper to you. But in short, a 10x8 unfortunately will not capture enough anatomy to provide you with a holistic view of the patient's condition, what is contributing to the patient's airway deficiency. Oftentimes we find that patients with airway problems are not just focused to suffer from oropharyngeal collapsibility. And if you're not familiar with the oropharynx, it generally is the back of the tongue. Yes, the back of the tongue and the tongue itself are major culprits when it comes to sleep apnea, but not the only culprits. And when we're looking to identify what's going on with the patient with airway deficiencies, we cannot ignore, for example, the condition of the joints. And a 10x8, which I would assume 10 centimeters in diameter, is not sufficient to capture the joints because the majority of adult males in America, for instance, have a distance of 15.5 centimeters in diameter from ramus to ramus. So if you have a 10 centimeter diameter, you're not going to capture the majority of your patient's joints. That's one aspect of it. The other aspect is if you only have 8 centimeters in height, you're still not going to capture the entire upper airway, right? When you're looking at patients with airway deficiencies, you have to look at the entire anatomy that starts at the tip of the nose, travels through the nasal cavity, down the oropharynx, and to the back of the throat. Because that entire pharyngeal space could be compromised and needs to be evaluated so that you could provide the patient with the right treatment plan. And in our previous discussions and in our previous sessions, I know that we highlighted, for example, a patient that was predominantly nasally pharyngally compromised, meaning the nasal cavity was mainly compromised and the oropharyngeal space was actually wide and open. So in that patient, moving the mandible forward would be contraindicated because it would bring no benefit to the patient to move a mandible if you are only focusing on the oropharyngeal space. So again, a long-winded answer to let you know why we recommend at the very minimum 15 centimeters in diameter and 13 in height. I encourage you to get the white paper so that you could read in more detail. And this is back with research, multiple sources to understand what part of the anatomy you really want to be looking at when it comes to patients with sleep disorders where the airway is impacting the patient's ability to sleep at night, and why the dimensions that we're recommending you should consider either for your existing cone beam machine or if you plan to refer the patient out to an imaging center. And Doc, is there anything else you want to add on that subject? Because I know it's an important topic.
I'm happy. Yeah. No, I showed a good slide on that, showing what happens when you don't have a full field of view. That's I think I don't remember what slide number it was. You covered it.
Okay.
Great. Jim, I do have one more question from Jerry. He's asking when you take the scans. He's asking, are the scans accurate to the situation regarding physical movement? I think what he's asking is because you're scanning and you're standing versus, when you're actually sleeping, and is there any difference in how is that compensated for?
Right. Yeah, well, that's what you tell your patient.
Oh, go ahead, Doc. Yeah.
That's what you say. Could you imagine you leaning back and what it's going to be like when you sleep at night? But go ahead, Sal. It sounded like you were going to say something.
Well, what I wanted to add, and I think we've said it in every session, but it's important to repeat it. The cone beam machines are not diagnostic for the purposes of sleep disorders. The cone beam machine is diagnostic for the purposes of dental comorbidities, right? So being able to understand, once again, the area of responsibility that the clinician is responsible for. What is the collapsibility of the nasal cavity? Again, that is a responsibility, an area of responsibility of the clinician. And what is the condition of the palate and its relation to the nasal cavity? Because we find often that high vaulted palates will infringe upon that nasal cavity and make it difficult for patients to breathe, promoting mouth breathing as opposed to nasal breathing, right? That's one example of it. What is the condition of the uvula? Is the soft palate collapsed, and how elongated is the uvula? So these are all things that you will be able to appreciate on a cone beam, even when the patient is standing awake or even sitting. And as Dr. Ataii mentioned, once the patient is laying down and the patient is fighting gravity and the patient is at their most relaxed state, the condition only worsens. So even though we're not able to capture in real time what that patient's airway looks like when they are asleep, the cone beam is still invaluable even without that data in front of us.
Perfect.
And it's also not practical.
Right. Looks like we have one last question. I think this would probably be for Dr. Ataii and for Sal. We've been talking about large field of view scans, the 17 by 15 or 15 by 15 scan. One question comes in is, Dr. Ataii, how are you involving your radiologists? Specifically, the question is, what information can we get from the image that shows the cervical spine? So, how are you, if you have that answer of like, what are the radiologists looking for as related to sleep dentistry?
Yeah. So what I'm sending I send the report is to pretty much cover what I don't know, right? So I know teeth. I know somewhat of an airway of the visual. I can tell you about soft tissue around the teeth. But if there's something in the nasal septum, if there's some sort of a lesion that's growing, or radiopathies or radiolucencies that I haven't been trained on, that's something that I need to lean on experts for. So why I give that option to my patients is because I tell them very openly, look, I'm going to look at your teeth, I'm going to look at your gums, I'm going to look at the airway structures that I know, and it's my field. Now, does not mean that I'm releasing responsibility, but I'd rather bring a just like an endodontist, right? I want to bring a specialist in, and that might be an extra fee, might be $100 or so more, but at least they can look if there's any issues. At that point, it's up to the patient to make that decision, right? They say, no, I don't want to do it. Okay, well, sign the consent that I've given you, that I'm looking at the teeth and oral structures, but I'm not looking at anything other than that. So that field of view is important for a radiologist or someone who's reading the x-ray that's an expert in that field. And again, I lean on sleep architects to find the right doctors. I just give the CBCT to sleep architects. They at that point have their clinicians, and they field out who the radiologist may be, or maybe it might be a neurologist or whoever reads this. So to me, it's a way of explaining to a patient that we're going to see a lot of stuff, and it's good for you to see. And that's why it's important for my team to kind of give a full diagnostic option to my patients.
Right.
Yeah, and I would
Sal,
I would add that, as you mentioned, Dr. Ataii, from our perspective at Sleep Architects, we look to involve as many allied healthcare providers when indicated. So on the subject of physical spines, for example, or the condition of the cervical spine in relation to moving the mandibles forward, we would bring physical therapists to be involved in the evaluation of those patients, or an osteopath, for example, or in the case of the nasopharyngeal space being compromised, bringing on an ENT that could collaborate in assessing and evaluating and developing that comprehensive treatment plan for patients. We've had patients with Hashimoto's disease, for example, where we've even evaluated the patient's drug intake and determined that after treatment, the patient required less dosage than the original dosage to manage their Hashimoto's disease. So, as I'm sure those providers that are doing sleep today, or those that are planning on doing it, will learn, this subject of airway deficiencies really takes clinicians through a journey, because you end up learning that a compromised airway has so many aspects of the body that get impacted. And you know, part of our lecture, and in fact it's in our previous session where I talk about not tackling this problem as a lone ranger, right? Involve other clinicians. At the very minimum, you want to have your primary care provider, the patient's primary care provider, in the loop, because an oral device is not going to tackle the patient's hypertension or diabetes. So from our perspective, we like to look at the patients holistically and understand how that airway is impacting the rest of their body. And again, this is why the additional data that comes from a cone beam gives us a tool set to facilitate communication with allied healthcare providers, not just the dental professional, but you know, the other providers that we can loop in to help the patients get that optimal care. And I hope that kind of answers the question.
For sure. And we have, if this, Howard was the one who asked the question, we've brought some radiologists on our past webinar sessions that we do address the cervical spine from a radiologist point of view. Howard, you can go back through those webinars, find the two previous webinars from Sleep Architect and Dr. Ataii, including other ones all the way back through April. Paul, I think that takes us to the end of our session today. It does not look like there are any other questions on the board. Dr. Ataii and Sal, thank you so much for your time these last 3 months, we'll say. There's a wealth of knowledge out there. We wish you best of luck. And again, thank you so much. If anyone needs any other information about Sleep Architects or Dr. Atai's practice, we will be sending a follow-up email to everyone. And then, Paul, we are going to switch over to a slide to kind of show us what Vatech is doing with our webinars coming up here in the next couple months, actually leading us through the end of the year. But again, Dr. Ataii and Dr. Sal, thank you again so much for your time. It's been a pleasure and a wealth of knowledge there. Again, thank you.
Thank you for having us. Thank you.
Gotcha. Paul, we do have coming up our next KOL event, our monthly webinar. We are going to be working with Amir Alan of Synergy Consultants and going over the financial and tax implications of COVID-19 on dentistry. So one of the topics that is he's going to talk about is assessing the tax implications of PPP and the HHS grants and EIDL loans and how to be prepared for 2021. So that's just a quick snippet of that. Monthly webinar following that, we're going to work with 3D Diagnostics, and Paul and I will be presenting with Omar from 3DDX on the initial scanning, implant planning, all the way through guide fabrication and delivery. And we do have one question about where we can get our CEs. Paul, that's coming up right here, I think on our next slide or one of our next slides. We'll get to that in a second, but our Customer Learning Center, if you do have questions of where these webinars are located, you can go to vatechamerica.com, Customer Learning Center, and then our webinar section down there highlighted in yellow for this one or any past presentations we have. And Paul, let's go to the next slide there. We should have our CE credits coming up here for the next slide. So you can go to sleeparchitects.com/CE, enter the code Vatech1007. Judith, this will also be in the follow-up email, this link there, so you'll have access to that. So everyone, I want to thank you all for participating these last 3 months in this series, and all the way, well, those of you who have joined us since April. We will be continuing this through the end of the year and into 2021. Please feel free to email education@vatechamerica.com with any topics that you would like to see in the future on this web series or that you would feel valuable, and any of your feedback from this session. Paul, I want to thank you for taking the reins here when my computer kind of froze here, but I think we made it through a great presentation from Dr. Ataii and Sal.
Yep.
And again, everyone be safe out there. And we look forward to seeing everyone either on our Fast Track Friday coming up in a few weeks on the 16th of October, or at our monthly webinar again. So again, thank you and stay safe.
Thanks, Jim.